The PowerPoint presentation for the coronary anatomy is coming up. Next. So basically we have two coronary arteries, the left and the right. The left divides into the circ and the LAD, as you know that. So this is just an intro slide to show you the different arteries. So the right coronary artery traveling down the right interventricular groove, the right atrioventricular groove, giving off the acute marginals as it's crossing the acute margin, and going behind and giving off the PDA, which travels down the interventricular groove posteriorly, and sometimes it gives off additional branches beyond that, which are called the posterolateral or the PLB vessels. The left main peeping in from behind the pulmonary artery and continuing down in the anterior interventricular groove as the left anterior descending artery. And at that point, at right angles to it, comes off the circumflex, which moves, which goes in the atrioventricular groove on the left, and that gives off the obtuse marginal arteries. The left anterior descending artery comes anteriorly. It gives off the septals into the septum and the diagonals onto the lateral wall. So this tells us the relative orientations of these vessels. You have on an RAO view the way you would view the interventricular plane and the atrioventricular plane. So that would be the interventricular plane at right angles to the interventricular plane at right angles to the atrioventricular plane. So how you would see that on an RAO, how you would see that on an LAO view. The interventricular plane has the LAD going anteriorly and the posterior descending artery going posteriorly. And around the apex, they meet. The atrioventricular groove has the right coronary artery going on the right side, the circumflex artery going on the left side. Next. So the vessels going in the atrioventricular groove form the circle, and the vessels going in the interventricular groove form the loop. So this is what is called the circle and loop concept. So this, if you have it in your brain and you know which is the atrioventricular plane, which is the interventricular plane, and what these planes do when you move them into the RAO and LAO views or any other view, and then you would know where to look for that particular vessels. So this is what you need to do. This shows you dissected blood vessels. You can see the LAD there running right in front of you, coming from around the pulmonary artery. And you can see the right-sided vessels giving off the acute marginal branch. This shows you something which is dissected a little bit more. We would show you this later on a specimen as well. The pulmonary artery has been dissected and has been moved forward. And you can see the left main vessel coming right off the left sinus. And that continues down as the anterior descending artery. That gives off the septal branches. You can see the first septal perforating down there, which is in relation to the pulmonary artery or the pulmonary trunk. So when you have to harvest the pulmonary trunk, as in say a Ross operation, the septal would be there and you need to be mindful of that. The circumflex artery comes off at right angles and it moves behind in relation to the LA appendage onto the atrioventricular groove on the left side. That gives off branches there, and that being the obtuse margin, those vessels are called the obtuse marginal arteries. You can see a small right coronary artery being given off at the right sinus, and that continues onto the atrioventricular groove on the right side. That probably there is a conal branch, and somewhere in that area, when you dissected the conus septum is probably the area where you will enter if you cut above the ventricular infundibular fold. That is something which we will show you later on in the day. So this is a specimen with the pulmonary trunk removed, and you can see the septals going down on into the septum. So the perforating septal branches are seen more clearer in this. This is another one which shows pretty much the anatomy of the proximal coronary vessels. Okay, so now we'll talk a little bit about the connections between the left coronary artery and the right coronary arteries. So this is something which is called the Vuessen's ring, which is the connection between the right and the left with its coronal vessels. Actually, there are three connections between the proximal right and the proximal left. So there is one which goes in front of the conus, which is called the preconal ring, the retroconal ring, and one which is retroaortic, which is the Kugel's interatrial artery. So these are all vessels which can open up when in coronary artery disease when there is a block. So these are proximal collaterals, threefold between the right and the left arteries. One of the first arteries from the right coronary artery may be a sinus nodal artery. In this picture, you see the SA nodal artery encircling the SVCRA junction clockwise. It may also do that anti-clockwise. Sometimes it may do it from both sides and embrace it. And occasionally, you do find an artery which may be given off from the left circumflex itself and traveling all the way on the roof of LA, reaching the SVCRA junction and supplying the SA node. So these are the pictures of the SA nodal artery. This is a picture of the base of the heart, which shows us the crux. And at the crux, you will find, if you can point it with an arrow, at the crux, you can find the AV nodal artery, which comes off to supply the AV node. So that goes somewhat in that septal area, in the crux, right between the two valves and supplies the AV node. So we will show you that as well on a specimen. So this is another vessel, which another base of the heart diagram, which shows you how the right coronary artery encircles the tricuspid valve, as also the coronary sinus, and the circumflex and the left circumflex artery encircling the mitral valve, and along with it travels the coronary sinus. Now we will move on to see some specimens where we can okay. So this is the aorta and the left sinus, the left main being given off from the left sinus, and that's about that long. And it continues down as the LAD. Okay. So the LAD goes in the anterior interventricular groove. So the left ventricle on that side, the right ventricle on this side, the LAD going like this and around there. So a type 3 LAD you could see going around the apex that way. When you go there, you'll see the posterior descending artery on the posterior part of the interventricular groove. Okay. So now, going more proximally, the pulmonary artery has been dissected there a little bit, and you can see the septal perforators. Okay. So the left main, LAD, septal branches. The diagonals would come off on this side. Okay. This is a ramus which comes off from exactly where the bifurcation into LAD and circumflex takes place. So then we call it a ramus. Any vessel on this wall is a lateral wall vessel. So as far as coronary surgeons are concerned, we just need to revascularize a lateral wall vessel. If that vessel takes origin from the LAD, we would call it a diagonal. If it takes origin from the circumflex, we call it an obtuse wall, and this is more anatomical. The circumflex moves around, and this is the appendage, LA appendage. See, nice long fellow, and the circumflex goes around its base this way, giving off the obtuse marginal arteries along as it goes. In this particular specimen, you find the SA nodal artery being given off by the circumflex. So this fellow travels all around the other way to the SA node. So in this specimen, the SA nodal artery comes off from the circumflex. Okay. So the right artery comes off the right sinus. So this is the pulmonary trunk, the conus. Somewhere there will be the area where you will come out if you cut above the ventriculoinfundibular fold into the region of the right coronary artery. So that is something which you don't do. Okay. So this is the RCA and the conal branch of the RCA. Then it goes around in the atrioventricular groove, and as it turns around, it gives off the PDA, which goes in the interventricular groove posteriorly. If we dissect here at the crux, you can see can you focus it a little bit? You can see the AV nodal branch. So that is the AV nodal branch. Okay. So the crux, at the crux, you find the AV nodal branch here. So too much of crux disease, if this vessel gets blocked, you can have a block, complete heart block also. So that's the AV nodal branch which is displayed here for you. Okay, next. Shall we have the Jasmine? Perfect. No, we need to show that left. Okay, no we. No. Just with Zula. Yeah. So, how do we recognize these vessels on an angiogram? So, for that, we built a little cath lab here to explain a few things for you, so that you could, so that it will be of ease for you to figure out what the angiographic views are. So here you have this man, head end. So this is the cephalic side, the caudal side, and the patient's left and the patient's right. So this is the C-arm. This is how you see. So this here would be the gun which would shoot the X-rays, and this is imagined as the camera. So when the patient is being angiogrammed, this is how the C-arm is going to be. For all practical purposes, we forget the gun. Throw it away. All we need to worry about is the camera. So this camera is your eye. So when you look at this patient from the front, this is an anterior view. Okay, so if you go to one side, it's a lateral view. This is an anterior view. Mostly we do oblique views. So when we need to do a right oblique view, this is how we are. The gun would still be at the back, but we do not have to worry about the gun. We do not think about it at all. We only think about the camera. We see as the camera sees. So a right anterior oblique would be like this, and a left anterior oblique would be like this. The other tilts that we can do would be a cephalic tilt or a cranial tilt and a caudal tilt. So a cranial view would be with the camera more towards the head, and a caudal tilt would be with the camera more towards the diaphragm. So how do we see? Let's have a look at a few angiographic on projector. Get the camera on. So we have made some wire models of the coronary artery. This would help us to figure out using shadow play what the vessels would look like on a angiogram. So this is the okay. This is the wire model of a left-sided vessel. The left main, the LAD, the septals, the diagonals, the circumflex, and the obtuse marginals. And this would be the right coronary artery with the PDA and the PLB. Okay. So let's start off by looking at what the view will actually show. This initial view would show you the differences between LAO and RAO and how you figure that out. So you look at the vertebral column. The vertebral column will move towards the patient's left side in an LAO view and towards the right side in a RAO view. One behind. This is the second one. Yeah, the one before that. Okay, so the vertebral column, you can see that moving, that this would be the LAO and this would be the RAO. This is as per we look at the patient, okay? It may be to our left and to our right, but we need to look at it as it is for the patient. So the vertebral column going towards the left would be the LAO and the right would be the RAO, okay. The cephalic and or the cranial and the caudal tilt, you would see with the second. So as you keep going, no, the next one. Okay, so when you look at it cranially, you see more of the diaphragm, and when you see it caudally, the diaphragm tends to move away. Okay, so that is how. So you see more of diaphragm, it's a cranial view, and when you see more of less of diaphragm, it's a caudal view. When you look at something cranially, you see more of the distal part of the vessels. And when you see something caudally, you see more of the proximal part of the vessels. Okay, so that is how these views are easy to remember. Next one. Okay, so now let's see what a RAO cranial view of the left side will probably show us. So this would probably how it would look like, with the LAD going that way, the septals coming this way, and the diagonals going the other way. Next one. So have a look and see, and you probably see the same thing happening here. So if you make a little wire and see how it looks like on a shadow, you could figure out what the view is. So this is a LAO cranial shoot. Next. Okay, I'm sorry, an RAO cranial shoot. Okay, so an LAO cranial shoot, next. You move towards the left side. And this would show you the LAD this way and the obtuse marginals coming the other way. Okay, so we see in between this area with the diagonals. So in a LAO cranial, you see the LAD coming this way with the diagonals being seen here. Next. Okay, so look at that. Okay, so this is a LAO cranial view. Next one. Okay, so if you have to do the same thing on a caudal shoot, this is probably what it will look like. Okay, so the vessel, mostly you will be seeing the left main and the LAD going this way and the circumflex going the other way. So this is what you would see in a LAO caudal. This is the classical spider view as it is called. Okay, so you see the left main and the proximal parts of the left-sided vessels in this spider view. Okay, next. So now we need a view to see the obtuse marginals very nicely, and that is the RAO caudal view. So this is how you see the obtuse marginals well, and this is the RAO caudal view, and this is what it looks like on the angiogram. Okay. Now let's move on to the right coronary artery. Okay. So a plain RAO view would probably be something like this. Okay, so this would be a plain RAO view. You see more of the right coronary artery in itself, but you find that the PDA and the PLB are kind of bunched together. You really cannot differentiate them in this view. Okay, so this is what it is. A lateral view would show you the mid part of the RCA better. So this is kind of an angioplasty view and more so favored by the cardiologist. And they would probably be looking at the lateral, at the mid part of the vessel and see where they could probably angioplasty something. So this is what it looks like. Now we really need a view to make the PDA and PLB be seen separately, and that would be the LAO cranial view. So when you move it, when you give that cranial tilt, it separates out the vessels that way. Okay, so if you see here, you will find that the PDA and PLB are separated out, and that cranial tilt has made sure your more distal vessels are seen better and separated out this way. So this vessel, this view would show you PDA, PLB nicely widened out like this. Okay, so using this sort of wire shadow stuff, you could make out the different angiography views and what will be seen in which view, and perhaps you can come about with your own friendly views as well. views that will help you figure out where the disease is and where you could graft the concerned vessels. Now, these vessels, what part of the heart do they supply of? So, what part of the heart do they supply? The left anterior descending vessel supplies most of the anterior wall and a chunk of the septum. So, that is probably the most important vessel, and that supplies the anterior two-thirds of the septum, a huge part of the anterior wall, and as it moves around, it supplies some of the LV around it as well. The yellow is the circumflex territory, and that is the lateral wall. The base and the inferior wall supplied by the posterior descending artery. You change your view. The inferior and the diaphragmatic surface is more supplied by the right coronary artery, the PDA from wherever it comes from. Let's talk a little bit about dominance now. When you say it is right dominant or left dominant, what do we mean? Right dominant artery would supply a right dominant artery would supply a large part of the PDA and the PDA area. So whichever vessel supplies the posterior descending area or the posterior descending artery is that particular dominance. So normally the right coronary artery would supply the posterior descending artery, and beyond that give off a posterolateral or a PLB artery as well. So this is a classic right dominant system. So the right coronary artery has given off the PDA and has given off one more vessel after the PDA. If it's a left dominant system, the PDA would come off the circumflex. So that's what we call a circ PDA. So whenever you have a circ PDA, you say that it is a left dominant system. The AV nodal artery comes off from whichever that particular dominance is. So that is also another way of deciding the dominance. So that brings us to what is a codominant system. A codominant system is something where the right coronary artery gives off the PDA as its terminal branch. So the PDA is the last branch of the right coronary artery. It is called a codominant system. Okay, there are many ways of interpreting dominance, codominance, etc. But this would be the most easiest way. Up to PLB from the right, right dominant. Last branch being PDA, codominant. Circumflex coming off from the PDA coming off from the circumflex, it's left dominant. Okay. Okay, so this is the cardiologist diagram where they try to give all sorts of numbers for the coronary arteries, and they have different classifications. Well, let's not worry too much about that, but that's just for you to know about. Let's look at some things which will tell us how you position the heart and how you make these vessels come about in front of you so you could graft them. We use what is called a sling. We pitch a sling somewhere in the region between the two inferior pulmonary veins or a little bit lateral to the left pulmonary vein. Either way, it's fine with us, whichever suits you. So that is where we pitch it, and this is how we have pitched the sling onto that with a rubber snugger. So you have these two vectors which are affecting the pull, and that would be the resultant vector, and the heart moves that way, and you get it in position. So if you do not pull up the sling, the heart is in the LAD position, and you can stabilize the LAD like this. So all you need to do is to pull on the rubber. You do not need to pull on the cloth sling, and the LAD is in place. So once you graft the LAD, you put a limb on the LAD, and now this is the diagonal which is in position. Probably you may need to slightly pull on the cloth sling to bring the diagonal into view. When you pull on it like mad, the heart is verticalized and the inferior surface comes into view. And this is the posterior descending artery, which is positioned with a little bit of a head down, and that's the PDA which is being stabilized for grafting. And this is the obtuse marginal. This probably is the last OM, which is done with the head down and the table towards the surgeon, and the sling being pulled up to verticalize the heart as well. So those are the different positions in which you get the heart to stabilize the different blood vessels. A few words about the venous drainage of the heart. The venous drainage of the heart takes place in three ways. So one is the coronary sinus and its tributaries, which form the majority, by far the majority of the venous drainage, the anterior cardiac veins, and a bit of venae caudas minime, or what we call the Thebasian veins. So the coronary sinus and the tributaries. Pretty much they correspond to the arteries. So you have the great cardiac vein, which is in the anterior interventricular groove, along with the LAD. And this guy, he moves around the left circumflex, moves around the left atrioventricular groove, picks up branches from the lateral wall of the left ventricle, the posterolateral, the posterior, the lateral veins and the posterolateral vein. And then as it takes on the oblique vein, it becomes the coronary sinus. The oblique vein is the obliterated left common cardinal vein, which is an embryonic remnant. So once that is drained into this vein, it becomes the coronary sinus. And then it takes on a few more branches, the middle cardiac vein being one of them, sometimes a small cardiac vein. And then it enters into the right atrium. This shows you the middle cardiac, the oblique vein of Marshall, which comes down at the back of the left atrial wall. This shows you the valve of Busen's. So what is this valve of Busen's? It is a valve which you find within the coronary sinus, probably just after the posterolateral vein has joined it. And this comes in different morphologies. You can either have one valve, two valves, three valves, and depending on whether most of them are flat or concave, they're divided by different authors into different types. The one which is shown on the screen is in 5 types. So this is the valve of Busen's. Remember, this is not the Thebasian valve that we're talking about. This is the valve of Busen's, which is the valve which is right into the coronary sinus. This probably bothers the electrophysiologist more and not us when we put in a coronary sinus cannula. Okay. This is something which I thought I'll mention in passing. This is the subthebasian pouch of Keith, which is a little bit of a pouch which is seen in relation to the inferior vena cava. It is inferior to the coronary sinus and somewhat anterior to the inferior vena cava. And this is an area which is very irritable, and this area may be considered for radiofrequency ablation in atrial arrhythmias. Okay. The anterior cardiac vein, there are a bunch of veins which drain most of the RA anterior wall, a bit of the the RV anterior wall, and a bit of the RA, and they may drain either separately through a right marginal vein or as multiple veins into the right atrium. The venae caudas minime are small veins, they call the Thebasian veins, and they drain directly into the chambers of the corresponding chambers. So more so seen on the right side, more so seen on the atria, which means RA has got maximum, a bit in the LA, and very few in the right ventricle, and almost no in the left ventricle. Okay. This is a coronary shot. Wait for the levo phase, you will find the coronary sinus. There it comes. So you find the coronary veins on the levo phase, and that is one way of figuring out where the veins are. This is a direct injection into the coronary sinus to show its branches. So I suppose this should be this should be enough for the coronary veins. And let us move on to the right atrium.